Hello everyone. We are just about to get started. Make sure all the slides are showing up appropriately here. Okay, great. Well, hello everyone and welcome to the GIN North America webinar series. My name is Brian Lees from the GIN North America Steering Group and the Center for Evidence-Based Practice at the University of Pennsylvania Health System. I am the moderator for today's webinar on GRADE, What's New and What's Next. Before we begin, I'd like to thank the American Academy of Neurology for kindly allowing us to access their webinar platform today. We really appreciate your generosity. And of course, thanks to all of you for participating today. Please note that the slides and the recording of today's webinar will be available on the GIN website next week. You see the website right there on your screen, so please feel free to take a look next week. And also, all of the previous GIN webinars are available on the website as well. So please poke around and take advantage. There are so many wonderful resources up there, and we'd love you to take a look at ones you have seen, ones you haven't seen, and enjoy them and learn from them again in the future. Also, of course, do not forget that registration for the annual GIN conference is open. The deadline to submit your abstracts is just under 2 weeks away. This year the conference is in Adelaide, Australia. The theme is Trustworthy Evidence for Questions That Matter. And for those of you who have been there, you know this is a great opportunity for everyone who works with guidelines on development, methodology, implementation, evaluation, to come together and exchange ideas, network, and learn about all that is exciting in the world of evidence-based medicine. If you haven't had a chance to attend one of these meetings in the past, we certainly strongly encourage it. It's really a unique opportunity that only comes up once a year. Now let's go to today's talk. There we go. In our 2019 webinar portfolio, we are featuring ongoing research, completed research, and a number of innovative tools that are available to guideline developers. Today's webinar is an update on GRADE, which stands for Grading of Recommendations, Assessment, Development, and Evaluation. The GRADE methodology is renowned internationally as a leading framework for assessing the strength of a body of evidence in systematic reviews and clinical practice guidelines. Today, we are fortunate to have with us Dr. Holger Schoenemann to talk about current and future developments for GRADE. Dr. Schoenemann is chair of the Department of Health Research Methods, Evidence, and Impact at McMaster University. He trained in internal medicine, preventive medicine, epidemiology, and public health, and has contributed to more than 600 peer-reviewed publications. He has also led and participated in numerous high-profile guideline panels, including the World Health Organization, the American College of Physicians, and he was a key contributor to the revised methods used for WHO guideline development and the GIN McMaster guideline development tool. He is the director of Cochrane Canada and the GINATA Working Group, and most importantly for our purposes today, he is co-chair of the GRADE Working Group. And despite all of those responsibilities, he still manages to maintain an active clinical practice too. Please note that all participants were muted when you entered the webinar to ensure a smooth recording of the session. However, we definitely want to hear from you, and we'd like to make this as interactive as possible. So please, throughout the presentation, note that at the bottom left corner of your screen you can submit questions, and we will be feeding those to Dr. Schoenemann throughout the webinar so that he can respond accordingly. So please feed your questions at any point throughout the webinar, and we will attempt to answer them as best we can. All right, I think that's it. Thank you. And let's get started. I'll turn it over to Holger.
Thanks, Brian, very much for the introduction. I'll be there in just a second. I'm starting my presentation. Can you hear me okay right now?
Yes, we can.
Okay, great. Wonderful. Thanks for allowing me to be on this webinar today. And I'm just going to do a few things, introduce where I'm speaking from, although most of you will know where McMaster University is, and just a brief reminder that it would be ideal if you ask questions as I go along. That will make for a better webinar by experience. That way we can address issues as they arise, in particular with the topics of today's webinar, which is what's new and what's next. you can just imagine that this is not going to be that there's going to be more than one topic covered. So I will once again just double check that you can see my presentation appropriately. I'm going to my next slide here really. Okay, so this is how this works. I hope it works like this. So I'm speaking from McMaster University. We're located close to Hamilton, and despite the fact that we are doing this webinar in North America, McMaster is not the same as McGill. McGill is in Montreal. We're widely considered the birthplace of evidence-based medicine and problem-based learning that started over 50 years ago. If you want to know anything more about the department, just Google us, please. Health Research Methods, Evidence, and Impact. I have a few disclosures to make. So Brian mentioned most of them. These are intellectual conflicts. I co-chair the GRADE Working Group. The views, however, that I express here are my own. And some of the slides that I'm using are from other members of the GRADE Working Group. And I'm very thankful. I will mention them as I show some of these slides. So today I was really asked to speak about, as I already said, what's new and what's next in GRADE, and there's a fairly long list. I'll take you through a very brief background about GRADE. I guess most of you will be familiar with the work that we've been doing, or even be obviously members of the GRADE Working Group. Speak very briefly about just an update on network meta-analysis, then GRADE for values and preferences. Again, this is a relatively, these are relatively brief sections. Update on diagnosis, also there a brief section, and use some applied examples. In particular, I will talk about our collaboration with the American Society of Hematology on guidelines that we are currently still producing, and the guidelines that we have already produced with ASH, and provide a few online demonstrations for what we are able to do nowadays in terms of bringing recommendations closer to those who use them. I'll speak about GRADE development, which is essentially an approach to adaptation, adoption, or de novo development of individual recommendations based on existing guidelines, and talk a little bit about evidence sharing in that context. And then if there's time, depending very much on your interaction with me, I'll speak about integration of non-randomized studies and randomized controlled trials, so NRS and RCTs as I abbreviated them here, and introduce one of the next topics, or one of the topics, that we've already worked on for a few years, but that is a priority area or focus area for GRADE, and that is environmental health. So that's kind of what I plan to do. Again, as I said, I might not get through all of this. I was informed that you would have all of the slides available. It very much depends on how interactive we can be here, and I encourage interaction. Again, for me, webinars are more informative if there is interaction, and it's actually nicer to follow them. I'm unable to share my camera, and I think that's not doable right now with ReadyTalk. But I can tell you that the picture that we showed, I'm not sure who sent it, is me about 6 years younger. Okay, so webinars about GRADE is our website address. And just as a brief background, after about 20 years of increasing confusion, starting in 1980 really, and then GRADE beginning in 2000, GRADE developed a unifying, transparent, and sensible system for grading the certainty of evidence and for making decisions, in other words, for grading recommendations. And this is a quick reminder, we use the terminology certainty of evidence, quality of evidence, or confidence in estimates interchangeably. Our preferred term now is certainty of the evidence, to avoid confusion with what is often considered the quality of studies or the quality of a systematic review. But you might as well use strength of evidence if that's what your organization prefers. And GRADE has been developed with many organizations and individuals involved. Over 100 organizations use GRADE, and GRADE is really for evidence synthesis, where we include health technology assessments. So GRADE is increasingly used in health technology assessment, but has been used in that field for also about for over a decade. And guidelines, obviously, there is over 600 contributors globally. I'll get back to that in just a second. And we literally have developed thousands of recommendations. Our work that is still ongoing in terms of scientific publications started really in 2004, but we refer to the 2008 and 2016 BMJ series as more of the final product. And then in 2011, we started publishing our updates in the Journal of Clinical Epidemiology and in now Environmental Health International. I'll get back to that. And the work has been widely cited. The go-to tool for GRADE is the GRADE handbook that is available online and that is currently undergoing a major overhaul to better, and this is a news, to better serve those who are using it. And then GRADE's official IT application is called GRADE Pro GDT, so GRADE, the GRADE Profiler and Guideline Development Tool. And which by the way is maintained, has been maintained by us for now about 15 or 16 years through various research grants that we had, and is now so sophisticated that there is a large team working on it. It becomes more difficult to support just through research grants that we are bringing in, but is a very helpful tool. I'll come back to that in a second. And then over the last few years, really starting in about 6 years ago, with the first center at McMaster University, we've created an international collaborative community of GRADE centers and networks. Many of you will not know that, but we now have 16 centers and networks approved. You see them here on the map. There is some the red represents that there is either one or more centers. So, for instance, in China, we already have 2 centers. In Australia, we have 2 centers, one or more centers, or there's a network, for instance, in the UK, in the US, and in South Africa, where groups from different institutions work together because singly they felt that they were not large enough or strong enough, but as a community in a country, they collaborate and provide support for GRADE. The centers are not geographically limiting. It's more that often proximity helps, but certain centers have certain strengths and do more work in one area than others. So that's an opportunity for many, and we have quite a few ongoing requests with regards to developing more infrastructure across the globe, really, at this juncture. And then another interesting part of GRADE over the last few years that some of you will be familiar with, but not everybody, is that we have created GRADE project groups. These are groups that work under the umbrella of GRADE together to advance certain aspects in GRADE, and I will touch on a few of them. So, for instance, GRADE for network meta-analysis, GRADE for non-randomized studies, risk of bias integration, and I'll touch on the evidence to decision project group and the work that has come out of that. And I talk about the outcomes evaluation project group as well. So these project groups have set terms of reference, deliverables, and developed the GRADE approach further. And the most important thing that I can probably say about GRADE is that membership is for free. We hold meetings typically twice a year, sometimes 3 times a year. There's always one meeting that is a dedicated meeting, 2 days, sometimes 3 days, to advance GRADE methods. And this year it's going to be actually in Hamilton. This is the second meeting that we held 15 years ago was the first one. But anyways, the meeting is in Hamilton, June 13th and 14th. Unfortunately, it's booked. But our next freestanding meeting will be next June, in the second half of June, with the final date to be determined in Krakow, Poland. And then we typically have a meeting around the GIN international meeting. So there will be a meeting in Adelaide that those of you who would want to sign up can sign up for. And Zach Mann is obviously the organizer for the GIN JBI meeting in Adelaide that Brian just introduced. And our meeting with the GRADE working group will be following it will be the day following the official program. Okay, so and then we hold a meeting around the Cochrane Colloquium as well. That's for introduction. So and then just very quickly, just as a brief reminder, so GRADE, as was already mentioned, involves assessing the certainty and evidence and certainty of evidence, which basically means that we emphasize assessing evidence transparently. We are interested in the confidence the confidence of an estimate of an effect or an association, including test accuracy values or estimates. That starts with a single study and ends with a body of evidence, obviously, and then we develop structured healthcare recommendations. Also there, our focus is on making judgments and decisions transparent. We now use what we call GRADE evidence to decision frameworks that resulted from our DECIDE project that was funded by the European Union from 2010 to 2015. And this includes a comprehensive list of criteria that I will review with you that influence the direction and strength of a recommendation. And we end up with what we believe is a clearly developed and formulated message for action that either is a strong or conditional recommendation for or against an option. But the evidence to decision frameworks are also used in the context of coverage decisions. There's an article that I will show later by Eleanor Pamelli that focus on the use of GRADE for coverage decisions. And there has been work by Philip Dahm with the US GRADE network that also looked at the coverage decisions and was kind of a precursor to that work on the evidence to decision frameworks. So quite a bit of work in that field as well. So it's not only about guideline recommendations. Okay, let me, so the first, again, this is about what is new and what is planned. The very recent work that has been published, and I'm not necessarily referring here to unpublished work simply because of the nature of having to go through submissions, but at the GRADE meetings, we always talk about unpublished work and basically get the work ready for publication. In the webinar, given that it's public, I'm referring to published work for the most part. So the first topic that I'm going to briefly cover is network meta-analysis, so multiple intervention comparisons, and these are the 4 papers that are available so far, just listed here. One being so the first paper that we had on network meta-analysis was a paper that was published in the BMJ now quite a few years ago, 5 years ago. We then published a paper that advanced that approach and made it more doable. We addressed issues around imprecision in network meta-analysis, which is a very common topic, and then we addressed issues around incoherence, which essentially, which I will get to, is important differences in direct estimates and indirect estimates of effects from network meta-analysis. So just very quickly and this is not a detailed methodological conversation today or talk today. It's about once again the overview of the eventual of the topics. Network meta-analysis is essentially an extension of a traditional meta-analysis where we're looking at 3 or more interventions, and this is an example for nicotine replacement therapy where you could have simple patches and compare that to medication, to oral medication that is being used to facilitate smoking cessation. One might legitimately ask, what is the best intervention to help people stop smoking? And there would obviously be direct evidence. For instance, if we compared varenicline, and bupropion, and there might be a direct comparison, or there may be an indirect comparison. So direct comparison would be here, or there may be indirect comparisons versus nicotine replacement therapy if there was no direct trials or observational studies that compared those two. And then finally, there would also be an estimate that would come from combining all of the data, if there is a direct estimate and an indirect estimate, combining all of the data, and we would call that the network estimate. So network meta-analysis has a number of disadvantages. I'm not going to talk about the advantages here, but it relies on more assumptions than a traditional meta-analysis, requires much more statistical expertise. Often there's a lot of information which is very hard to make sense of, and most importantly, then expressing at the end how certain one can be in the messages from a network meta-analysis is even more challenging. In other words, the rating of the certainty of the evidence is more challenging. And so over the past 5 years, in particular with the past few years, with Romina Brignadella-Peterson leading that work through a postdoc and now in a faculty position, we've made what I consider important advances. So I'm just going to highlight this a little bit more for where GRADE has provided some guidance and is continuing to develop guidance. I'll get back to that. So, for instance, this is a different example. One might, from a paper that was published in the Annals of Internal Medicine, that looks at different, once again, different types of smoking cessation methods. And so nicotine replacement and therapy, NRT here, if everyone is interested in a comparison between nicotine replacement therapy and antidepressants for smoking cessation, one would have a direct estimate, direct evidence, for instance, from 3 trials that would indicate that antidepressants seem to be superior. But then if one looks very carefully, there's a lot of indirect comparison. So 67 studies that have compared nicotine replacement therapy with control, for instance, placebo, 29 here. And the first question that one could ask is, what is the effect if we included that indirect evidence? And this would be the effect estimate there. But it becomes very obvious that this, what we consider to be the closest loop here, could be supplemented by more distant loops where there's additional comparisons. It becomes more and more indirect, as you can tell, and it provides additional estimates. At the end, for this particular network, there is at least 5 pathways to indirectly compare antidepressants to nicotine replacement therapy, and it could become difficult to make potential sense of it. So if we just think of the network again, of the key comparisons, there were, as I mentioned, 3 trials that provide that provide a direct meta-analytical estimate of the effect, and then there are 5 estimates from indirect loops that one could pull in as part of the information. So GRADE has, just in a nutshell, without going through the details, there's lots of education about network meta-analysis out there that I would recommend to look at. In a nutshell, GRADE has said, okay, that means that there are several ratings of the certainty of the evidence. One is rating the certainty of the evidence using the standard GRADE criteria: risk of bias, indirectness, imprecision, inconsistency, and publication bias. Rating the direct estimates, then rating the indirect estimates, where obviously indirectness is a key issue and a key factor for which one might rate down. and then rating the overall network meta-analytical estimate. And so the steps that GRADE has proposed here, this is now going to a different example. I apologize, different interventions, so don't get confused, but it's the same principles. So the first is one presents the direct and indirect estimate for each comparison of the evidence network and makes a rating there, which is the second step. And then we would look at the network meta-analysis estimate and make an overall judgment about that, which may include judgments about indirectness, but it may also mean that if there is coherence in the estimates, that, for instance, concerns about imprecision that may have arisen from the direct evidence may be alleviated by in the network meta-analytical estimate by combining the indirect and the direct evidence. Okay, so that is laid out as steps in the paper. A few other things that we've addressed is in summary, what GRADE has suggested is that if there's only direct or indirect evidence, then one would obviously use that type of evidence. The next step is to see what if the direct and indirect evidence would differ in contrast to what I just said. Then one would have to come up with different solutions. So if there are two estimates, both direct and indirect evidence, we would use typically the higher certainty of the evidence, but because it wouldn't make any sense to add evidence that is of lower confidence or lower certainty. However, if they differ, problems of lower certainty probably haven't provided misleading results. Or the problem is that if lower certainty evidence hasn't provided misleading results, then one would face the problem of bringing this information together. And that's where we suggest to look carefully at the coherence between the direct and the indirect estimates. Again, if there is some similarity of point estimates or overlap of confidence intervals, and there are statistical tests in the typical guidance, then this is known. If there's difference, either as consistency or coherence, and that can be evaluated at the network level or at the level of the paired comparison within the closed loops. So that's the coherence assessment. So coherence between the direct and indirect evidence. If there's incoherence, then use the estimate with a higher certainty. If you can explain the incoherence, then even if the evidence is of the same certainty, then use the one that you would think there is more trust. And if you cannot explain the difference, then unfortunately one might lower the certainty for incoherence. The same is true for a concept that is called intransitivity. So there's a paper coming out that has come out that deals with intransitivity. And intransitivity basically relates to that if one cannot conclude that intervention C is better than A from the results, if the network indicates that C is better than B and B is better than A, then we have intransitivity. In other words, if you were to compare C to A, and it indicates that C is not better than A, but the individual comparisons of C versus B and B versus A would suggest that C is better than A, then we deal with intransitivity, and that needs to be factored into the potential ratings. So, just in a nutshell, our approach then to network meta-analysis, which is obviously a topic that requires a lot more guidance, is that we're rating the direct estimate, we're rating the indirect estimate, including an assessment of intransitivity, and then we'll do the rating of the network estimate after both of these estimates have been rated, which then includes also a rating of incoherence. So this is just a quick update on that, and together with that, not yet official GRADE guidance, but we've developed ways of presenting that information in summary of findings tables. So where the summary of findings tables obviously includes the PICO question, then a graphical display, the geometry of the network, and individual ratings where we suggest at this point to produce or provide the best estimate of the effect, in this case all network estimates, but sometimes these may be direct or indirect estimates. So that's all work ongoing on network meta-analysis. Brian, I will just stop here quickly if there are any questions. Otherwise, I'll move on to the next topic.
Yeah, Holger, let me pause for a minute. We do have a handful of questions. Some of them are more general about GRADE, but let me pose the first one, and I'll read them briefly so that they make their way into the recording clearly. Do you see a role for high-quality case reports, for example, those following reporting guidelines like the Equator Network, in providing feedback from the point of care when it comes to clinical practice guidelines?
So yes, so there is also work that we've done with in a project that was called the Rare Disease. That was the Rare Best Practice. Sorry, a European Union funded grant, again with involvement of the American Society of Hematology, so essentially the way that we are dealing with case reports or case studies is the same way that one would evaluate a non-randomized study, where there would be not very often, there would be usually further rating down for risk of bias. But case reports could be utilized, or individual cases could be utilized and put together as that type of evidence. There's some examples, I'm not referring to it here, I could have. There's a catastrophic antiphospholipid antibody syndrome guideline that you could Google, where we applied that approach. And there's some work coming out that deals with how to utilize that type of evidence in the context of guideline development. So the answer is yes, yeah.
Okay, great. And we did get one question specifically about the content you just covered, and that is, does the GRADE approach for network meta-analysis apply to all the different types of network meta-analysis models?
We believe yes. Models meaning all sorts of comparisons or different statistical techniques. But regardless, in that latter paper that I cited by Romina, there is information provided about that. Yes, there was a few other questions, general questions that I can quickly address, Brian. Challenges that an organization may face when adopting the GRADE methodology. Well, we obviously think it makes things easier if you're already doing systematic reviews, but obviously you do need training in guideline methodology, and there will be further work by Jin to support organizations in being properly trained in using guideline methodology, and GRADE is just the system that makes the judgments more structured and transparent. But of course you need expertise like in any field of healthcare. We feel personally it's not acceptable that with the importance of clinical practice guidelines, that you would not be appropriately trained in guideline development, including concepts that GRADE has put together, which is basically research methods, because of the impact that guidelines have. We would never let somebody without appropriate training do brain surgery, and the impact here could be even higher. There were a couple of other questions very quickly. Does the handbook content reflect current GRADE guidance? It does, with the only exception that some of the new topics are not covered, but this is being addressed. So there is dynamic updating, and we see we have planned for all of the current content to be available by the end of this year, and this is work that Jan Brozik is leading. Then can I comment on the difference between GradePro and Magic App? Well, all that I can say is that GradePro is the official GRADE tool. Over the years, as with any, I think with any successful tool, there are other IT applications, and The Magic app is one that also uses GRADE, but GRADE has always been our official tool, and the handbook in there is the official handbook. And then RNO is on the line, and we are very interested in the integration of NRS and RCT. I will address that guideline-based quality indicators. I'll be happy to comment on that. There is that's a general question. There is some guidance coming out for how to use evidence to decision frameworks in the context of quality indicator development. This guidance is probably going to come out towards the end of this year. There's a framework that we've developed with the European Commission that eventually will hopefully become GRADE guidance, and it's being dealt with in the GRADE quality indicator or performance indicator project group. So if there's interest, that's the group to join. That would be my brief answers. And Brian, if that's okay, I can move on.
Absolutely. Go right ahead. And keep the questions coming, everyone. Thank you.
Yeah, no, that's great. Thanks for the questions. And I hope that everybody can see them. That's wonderful. So GRADE for values and preferences. I will say that we use an alternative term as a brief introduction. An alternative term for values and preferences that also sometimes are called, although not technically fully correct, utilities. An alternative term, and that is the relative importance of the outcome. And what we are addressing here essentially is how important specific outcomes might be for decision making. So for instance, we may have an intervention that reduces mortality by 50%, absolutely speaking. Such intervention doesn't exist. Well, few interventions exist, but it reduces mortality by 50%, absolutely speaking. But it may lead to temporary nausea in 50% of patients as well. If we wouldn't assign an importance to this outcome, we would be unable to make decisions. In most instances, this is being done implicitly. However, obviously, with a great approach to identifying critical and important outcomes, and in health technology assessment and modeling, we are obviously weighing these outcomes. In other words, everybody would say these were the two outcomes. We would use the intervention because mortality is much more important than nausea, but we couldn't derive it from the effect estimate in itself. So there is a relative value placed on the outcome. And that's sometimes called values and preferences for treatments. Our approach to that is that patients or people place an importance on the outcome, not on the intervention, but the outcome that the intervention actually inflicts. So patients don't have a preference for surgery over a pill. They have a preference over not having pain, not being in the hospital, et cetera, where those are outcomes as opposed to an actual intervention. So we've dealt with this because there's a lot of literature about how important an outcome is. So for instance, that a stroke is more important than temporary nausea. We've dealt with this in a series of papers. Here are two guidance papers by GRADE that are very recent, that were produced by Ray Zhang, whose PhD work and postdoc work this reflects. And that focuses on when there is research evidence about what people believe is important or not so important. In other words, when there is evidence, for instance, about utilities or values that people place on outcomes, then if that evidence can be utilized to inform a guideline panel by saying, okay, this outcome is more important than the other, then we should also assess our certainty in that particular evidence. In other words, we should be looking at or thinking about how good the evidence, the underlying research evidence is. And as for any other pieces of or parts of the GRADE approach, we would suggest that there always is a systematic review of the evidence that is relevant for a particular outcome, and I will give you an example in just a second. Then use, when in that work, then use the same domains for the assessment of the certainty of the evidence that we use for interventions, interestingly enough. So when we did this work, we found that risk of bias, indirectness, inconsistency and precision, and probably publication bias, as well as a few other domains, may play a role. Those four that I mentioned here certainly were found to be relevant. And then there is a very good example, if you're interested in that, by, again, Ray, that was part of his PhD, that talks about how patients value COPD, where we applied this approach. And I'll give you a very quick example from that last paper. The relative importance of outcomes can be, as I mentioned before, it could be measured as utility, where utility of 0 reflects the state of being dead, and the utility of 1 reflects being at full health. And the studies that would have been done on a particular topic might have measured these utilities using, although not technically fully correct, but using a simple visual analog scale, as you're seeing it here. And then a systematic review could either produce a pooled estimate, or it could provide a range of estimates across studies. So for a exacerbation from chronic obstructive pulmonary disease, the pooled estimates across studies indicate a utility of 0.37 and a 95% confidence interval around that. Again, doing a meta-analysis, that would indicate that having an exacerbation from COPD is a pretty severe outcome and a pretty severe event. And what we've basically suggested is that we would then do a rating of the certainty of the evidence in that particular estimate. And there is lots of nuances to that. And in this particular case, we provided a rating of the certainty of the evidence and rated down the certainty for inconsistency that couldn't be explained. And then there is a narrative description of that particular information. Donna has a has a question: how useful is the International Consortium of Health Outcome Standard Set for the identification of critical patient-important outcomes? So I believe that COMET, the COMET initiative is a group that we collaborate with, extremely helpful. I think what we need to do is we need to, and this is currently underway, we need to link better the work of those who are working on standard outcome sets with guideline developers. There's a lot of work that is ongoing in this field. I haven't addressed it here today, but for instance, through the standardization of outcome descriptors, we call them health marker states, that can be used both in clinical trials and in guidelines, and ensure that we are talking about outcomes that people understand and that matter to people. So there's a collaboration. Happy to expand on that or have follow-up on that. Okay, so and that information then can also be summarized in a summary of findings table. So this is our standard, relatively standard format of a summary of findings table that brings together the key information from a systematic review. And you see here that, again, we talk about a health state or an outcome that is described in more detail. What does it mean to have an exacerbation? The estimates, the number of participants and studies, the certainty rating, and an interpretation. And that would be true for different types of outcomes that we potentially would be dealing with. Sometimes there's only a narrative description of the potential outcomes, but the key here is that for this type of information that is critical for decision making, we can also rate the certainty of the evidence. And it's done in the following way. The evidence starts as high certainty of the evidence. We consider what may lower the certainty of the evidence, and then have a final certainty of the evidence. and do this by looking at for risk of bias, for instance, looking at subdomains of the studies, such as selection bias, missing data, confounding, and then make a judgment across the subdomain level, for instance, risk of bias, and see whether or not that is serious or very serious risk of bias, which would lead to rating down. This is just another example to make the point a little clearer. So, for instance, the importance of the outcomes related to stroke, severe stroke, moderate stroke, major bleeding, and with a assessment with a description of the underlying studies, the participants in the study, the rating of the certainty, and an interpretation. So that information is seen as very helpful by guideline panels because they don't have to guess. And most importantly, we make judgment about the importance of outcomes that is consistent with what people think. Okay, I'm moving on to my next topic. This is going to be fairly brief, and I'm going to go into some live demonstration, which I think is particularly helpful. So again, just as a reminder for those of you who joined late today, the idea is to provide you with information about GRADE in terms of what is new and what may be coming. I'll present some of the later work on diagnosis or the use of tests. So in 2017, it was online published in 2016, we published the work on the GRADE evidence to decision frameworks for tests in clinical practice and public health, and then provided a updated paper on the GRADE approach for test and test strategies as it relates to going from test accuracy to patient-important outcomes and recommendations. These two papers go in tandem. And that basically deals with a number of issues that I will explain on the basis of a guideline that has been led by two colleagues, Reem Mustafa and Wendy Lim, and it's part of the introduction to the American Society of Hematology guidelines that were published in November of last year. And I will make sure now that you can actually see that information, which I hope is true. Just make sure, Brian, I will check with you that that information is actually visible. Can you see my browser?
Yes, we can.
Okay, very good. So live demonstrations always a little risky and tricky, but I will try it regardless. So these are the guidelines that we've produced here with the GRADE Center and various collaborators around the world. And this tells you about a few things. So first of all, we've standardized the presentation of information in guidelines. This is not necessarily something that required a great deal of research, but we felt very much that standardization of presentation of published guidelines is something that needs to be done, and we had done work over the years. But you see here that there's in this interactive tool or interactive way of getting to the web browser a number of things that one can relate to, and that provides you with an overview. But the most important thing that I meant to say is that we have followed GIN methodology for developing these guidelines and the GIN criteria largely, and that in that particular document, we've provided one thing that we found is possibly extremely helpful. We've provided detailed links. I'm just scrolling down. To make sure that you realize what I'm talking about. So we've provided information for each recommendation about the underlying rationale for making a recommendation. So we have for each recommendation provided an evidence to decision framework that supports an individual recommendation. So, for instance, if one clicks on one of these hyperlinks here, the actual, sorry, I have my, cannot move this little thing here, apologies. I will just use this. So you click on this particular link, and you get taken to information that provides more detail than just the actual recommendation. Background, if there were any subgroup considerations, justifications, a summary of findings table for test accuracy, more importantly, a flow chart or similar to an analytical framework that the U.S. Services Preventive Task Force presented that lays out the test treatment pathway for the individual recommendation. It provides, again, the evidence to decision framework, the PICO question essentially here, background, conflicts of interest for the individual panel members, and the description and rationale for why a certain suggestion or recommendation was made. So the key information for the test that relates to diagnosis and test accuracy here is that in GRADE we are now, I'm sorry for this scrolling, but it's important to show that we are emphasizing the use of these diagnostic pathways or analytical frameworks, although they are not exactly the same, to highlight and describe how recommendations are developed and what they are addressing. And then this information also included back of the envelope modeling to categorize how many patients would end up as being, for instance, negative and false negative and positive and false positive for various treatment pathways. I'll get back to that because the collaboration, when I was first asked about giving this webinar, one of the thoughts that came to mind is we should really, because there's so much interest and emphasis in this, we should really pay more attention as GIN, as the Guideline International Network, in highlighting the collaboration between the methodologists, the systematic review authors, and the professional organizations that are the key members of GIN, and to support each other in terms of the development of guidelines. And I will get to that. And ASH is a phenomenal, in my view, phenomenal example for where this has worked very, very well. And there's a question if there's a central repository or list of all the GRADE publications. The brief answer is yes. I will get back to that, but there are links to the publications that we are reestablishing on the GRADE website. But more importantly, I will show a database later on of all GRADE guidelines that has been developed by the Pan American Health Organization, and that is brand new and being released. So that's a quick answer, and then I'll get back to the more detailed answer from Jonathan, for Jonathan in a second. But I wanted to show you this because it is relevant for my next section here, and that is this collaboration with professional societies, where I use ASH as a North American example for doing this. And I will highlight the link to the evidence decision frameworks, as well as to the patient versions that we have developed, and how this information then can be used by others. I will cover these three subtopics for you. So just to come back to the general issue, in a nutshell, GRADE works like any other guideline, we use GRADE for in the context of any guideline where there's a question that demands a review of the evidence, and that review of the evidence should be done in systematic reviews of health technology assessments, and then the guideline panel uses that evidence to make a decision or a recommendation. This is a slide from Ignacio Neumann, who's done a lot of work in the development field that I will get back to in a second. And that then means, in a more complicated way for GRADE, that there will be a guideline panel. This is our famous slide. I once was at a talk with 4 individuals, and everybody was showing this slide, so I suspect that everybody on this call will have seen that. But it starts with a panel formulating a PICO question. I talked about the importance of the outcome. In GRADE, we focus on outcomes that are critical or important for decision making. It requires an assessment of single studies, and then a production of an evidence synthesis in a summary of findings tables, for instance, for the effect of an intervention with GRADE-Co. Then there would be a rating of the certainty of the evidence, obviously for the individual outcomes, or a summary of findings table or evidence profile. That information then is utilized again to make a recommendation, but it's not only the estimates of the effect. When I talked about, on purpose, talked about the test accuracy evidence or talked about the relative importance of outcomes, I mentioned that that can be presented in summary of findings tables with a rating of the certainty of the evidence. And that really means that a systematic review, hopefully through existing systematic reviews, supported by existing systematic reviews, is in the ideal world required to inform the criteria that influence the direction and the strength of a recommendation. I will make this a little clearer, but this is really where we're moving at. We have a lot of systematic reviews on intervention effects. We have systematic reviews on test accuracy. We have fewer systematic reviews on the relative importance of outcomes or utilities, but we are getting there. And at the end, when we can put all of that together, ideally through sharing of evidence, which I will also get back, our decision-making will be facilitated. So the evidence-to-decision framework, or evidence-to-recommendation framework, then means that a panel considers all of that information that relates, for instance, to the benefits and the harms of an option, the values, and the balance of these effects. So this may be the effect estimates, this may be how important the outcomes are and how much variability there is, what are the required resources, hopefully also that eventually supported by either modeling or reviews of models, including reviews of cost-effectiveness studies that are applicable, considering, depending on the perspective that the guideline panel takes, considerations around equity, so are the disadvantages for certain populations, acceptability of the recommended interventions, and the feasibility. So for instance, if we recommend a new surgical technique, and that surgical technique cannot be done by surgeons in a large area because there is no training, then something becomes infeasible. And one can recommend to scale up, or one can recommend, given that that is not available, possibly not, or only conditionally recommending it, just as an example. And then the panel considers that to make a recommendation for or against an intervention, and that can be a strong or conditional recommendation that then is put into a guideline as I just described. And again, a conditional recommendation is typically when these criteria, the information about these criteria is more balanced. A strong recommendation is when things are very clear. And so we utilize these evidence-to-decision frameworks that I showed you just in an overview, and we'll show you now in more detail. We utilize these evidence-to-decision frameworks to do a couple of things. One is to make sure that we are oriented to the task with the guideline panel. Two, that we have a structured process to follow, because guideline panels can derail very, very quickly. And three, that we have a transparent record and describe our judgments and keep a record of these judgments for when it comes to, for instance, updates. But we also use the evidence-to-decision frameworks for dissemination. So they start with a question: what are the potential subgroups? What's the background? They have an assessment component that includes the criteria that I just described, the judgments that a guideline panel makes, the research evidence, hopefully from systematic reviews, and any additional considerations. They include a section on the conclusions. What is the type of the decision that we're making? Are we making a recommendation or a coverage decision, a justification, thinking about how to implement, monitor, and evaluate, and research considerations that inevitably evolve from almost every recommendation. And then there's a presentation part to that, and that is really important. We use the evidence-to-decision frameworks now in our guideline panel meetings by showing them on screen and sharing them on WebEx so that people can work together, see the same information. They then also allow not only the conduct of guideline group meetings, but also they allow to feed into the database of decision frameworks and the production of apps and interactive decision aids. And that's all facilitated by the use of GRADE Pro. So I get back to the evidence to decision framework and just quickly mention that this information, these evidence to decision frameworks, the GRADE evidence to decision frameworks were developed, as I said earlier, by the DECIDE project. They are for coverage, health systems, diagnostic type of recommendations. They inform about the judgments that are made. They consider each important outcomes, including the importance of the health outcomes that I described. They are utilized to provide a concise summary of the best available research evidence to inform the judgment. They help structuring the discussion and identify disagreements, which is critical in guideline panels. And then they make the basis for the judgments and decisions transparent and adaptable to different target audiences. So this is still, as I said, relatively new and probably worthwhile mentioning here. The papers started to come out in 2016 in the DMJ, and then we did an evaluation and provided some background. I will show you now an example for how we applied these evidence to decision frameworks going back to our ASH guidelines. So in 2015, we started working with ASH. At the end of 2015, we started working with ASH and identified a number of topics in the field of venous thromboembolism. We identified with the panel over 200 potential recommendations. There was a large group of guideline development groups that was involved, so 10 particular guidelines. We collaborated, and part of my conversation today is really about this collaboration, because we need more of that type of collaboration between guideline developers and methodologists and systematic review authors to avoid duplication. So ASH really wanted to produce a comprehensive list of guidelines on venous thromboembolism, gain knowledge and experience to develop guidelines on other topics down the line, which they have subsequently successfully done on other topics or doing on other topics. For McMaster in this case, and the GRADE Center at McMaster, it was to really apply GRADE and gain more experience about the transparency and efficiency of applying GRADE. And then we obviously had some shared goals that was to produce guidelines that meet the highest standards, that are useful and used by clinicians, and then to produce guidelines that improve the quality of care received by patients. At the end of the project, there will be indeed all of that fulfilled. It was a big effort. As I said, at the end we had over 130 content experts, which was close to what we started with. Lots of methods experts involved, ASH staff, and it was a 3-year project that led to this production. And the way that it worked was very much based on the GIN McMaster guideline development checklist that is shown here, where I just wanted to briefly highlight that ASH had an oversight committee that dealt with conflicts of interest, guideline panels, individual guideline panels, and there were several working groups that did the systematic reviews. There was an external evaluation of what we produced by stakeholders, public comment period, conflicts of interest were considered carefully, and we transparently documented everything that related to the final recommendation. I want to get back to the evidence decision frameworks and how they were used. So what we essentially do in the evidence decision frameworks is to utilize the criteria, as I already said, on which a recommendation are based, make judgments together, happy to talk about this more, use research evidence, and add additional considerations. The way that it works in a real guideline is the following, that there is research evidence that is discussed by the panel, additional considerations that may be added, for instance, things that didn't come out of the research, of the review of the evidence, but were felt critical to let the audience know about by a guideline panel, or we would even document there that it had to come to voting on a particular criterion and documented the vote there. And then it would come to a judgment. For instance, how large the desirable health effects are, and this would always be done by panel members who didn't have a conflict of interest as per ASH definitions. I'll give you a quick example for that. So for instance, one of the recommendations focused on if in long distance travelers, we should recommend graduated compression stocking. So flying, long distance travel is a risk factor for venous thromboembolism. That is a commonly asked question, interestingly enough, and one that achieves most public attention when we talk about guidelines. The evidence, however, is obviously very interesting in that the baseline risk is very, very small, and despite a potential effect, the desirable effects were considered trivial by the panel. In other words, there was a very small reduction, only 3 to 11 out of 1 million travelers in deep venous thrombosis. And we felt that there was, however, no important uncertainty or variability in how patients value the outcomes. That is, nobody wants to have a DVT, and everybody probably does not very much like wearing compression stockings, but we felt there's little uncertainty around this and did a systematic review on that. So if you think of it so far, there's some factors that favor wearing compression stockings that may lead you to make a recommendation in favor. However, there are issues that do not favor graduated compression stockings. There are some undesirable effects. However, being very certain about it is probably limited by the fact that the actual evidence that supports a reduction of 3 to 11 fewer per 1 million, the actual certainty of the evidence is low. However, graduated compression stockings are probably acceptable and they are feasible to do. At the same time, on a population level, the cost would be moderate. You prevent only 3 to 11 DVTs, but 1 million travelers will have to buy these compression stockings that cost about anything between $20 and $50. So, and that would mean that those who fly with low-cost airlines would be unlikely to buy an extra stock of graduated compression stockings, and health equity could potentially be reduced. So that at the end, the guideline panel would have considered these factors in an evidence to decision framework and made a recommendation. So I'm going to go back to the guidelines that we did with ASH. So for instance, here again, we would have produced a guideline using that type of approach for travelers and medical hospitalized and non-hospitalized patients or people. And that is the particular guideline. So the same type of approach that I already showed you for the diagnostic guidelines. Here they are, and also the same thing here. Every single recommendation is supported by a link to an evidence to decision framework. It should be coming up here in a second. Give me 1 second. This may be a good question if there are for questions that may be there. Maybe Brian, has there been any other questions asked of you, because I can help go to the.
Yeah, nothing pending at the moment, but I actually have a question on behalf of my colleagues at Penn, I think. You touched very briefly a little while ago in terms of evidence decision frameworks and the role of health systems. Obviously, a big focus now generally is what we call learning health systems, at least in the U.S. now, in terms of incorporating evidence and incorporating local data as well, and trying to adapt the results of systematic reviews and clinical practice guidelines to local practice among major high-performing health systems. So in terms of some of these changes with evidence to decision frameworks and similar efforts, what are your thoughts sort of on how they can be best adapted, or where the strengths and weaknesses might be in applying that to health systems?
Yeah, no, it's a great question, and something that we are extremely interested in, and in particular in the context also of work that we are doing with Coherence. So learning health systems, and some consider it's important that we actually place emphasis on the speed with which health systems learn, and emphasize rapid learning health systems, as you know, Brian. So the way that I think this does work is best explained on the basis of an example. Unfortunately, I took this example out of the slide, but I will just briefly refer to it. We did a guideline for the World Health Organization. Many of you will know that example on a new drug that was used for the treatment of multi-drug resistant TB, and that new drug was bedaquiline. It was approved by various regulators, and then suggested to be used by WHO in 2013. However, there was a big problem with the evidence around a few things. Most importantly, the potential side effects. The one trial that had been done suggested a 9-fold increased risk in death, relatively speaking. And that was considered to be, that was based on a very small number of patients. So that new evidence was required to evaluate the true harm related to that potential medication that was very effective in reducing, in let's say, curing multi-drug resistant TB. And the point that I'm trying to make is that we had a evidence to decision framework that we produced for this original recommendation, and we were able to identify here are the research gaps. What we need is we need more data, even if it is from observational studies, because we knew that there was no trial coming on the risk of death. And what happened in the context is that several member countries got together, provided data for an individual patient data meta-analysis that helped us to then update that evidence to decision framework in a timely fashion, and to modify the recommendation accordingly. So where the emphasis here is on the transparent record that we have with the evidence to decision framework. The reason why we didn't make a strong recommendation was that there was a risk of death. Member countries and study groups provided data. We were able to look at that information again in a short time frame and alleviate concerns around the risk of death. So that's one way of thinking about it. I think the other way, Brian, of thinking about this is, for instance, in a guideline panel, you might identify gaps with regards to utilities, the use of a recommendation, and the integration, for instance, in medical records could include an evaluation of underlying utilities and the importance of the outcome that can be directly fed back into the recommendation and the guideline for it to be modified. And it very much gets to the point that we are piloting, that we hope to pilot, with ASH, the point to produce living recommendations by utilizing information from the context, essentially. Does that address your question?
Absolutely, thank you. It's a lot to chew on, so I appreciate it. And as you head into the next section, let me just remind everyone, we do have just about 15 minutes left, so if you have any questions that you want Holger to address before the webinar concludes, please start getting them in at this point. All right, thank you.
Okay, good. And this is just a quick, again, a quick show of what we think is really something that we owe the users of guidelines, so a more accessible information. So I mentioned the graduated compression stocking, so we made a suggestion against it in regular travelers without risk factors, and a suggestion for it if risk is increased, again, with justifications provided. And here the interesting part is that we now support all of that with interactive summary of findings table that can be utilized to graphically represent the data when there are pooled estimates and for users to better understand it. This is also supported by patient summaries. Again, I'm showing you one example. So increasingly, ASH is now using that information in the evidence to decision frameworks to produce patient versions that that help certain target audiences to better understand the actual recommendations. And then in this context, going back to my presentation, and this goes back to this collaboration effort that I described. In the context of one of the next guidelines, we are utilizing Cochrane's first living systematic review, which is essentially related in part to what you just raised, Brian, using new information as it comes in this case from new randomized controlled trials, to update systematic reviews on an ongoing basis. This work is led by Eli Akel, who heads the GRADE Center in Beirut, Lebanon, at the American University there. So we are increasingly utilizing the new developments to better describe or better utilize information as it develops. Brian, again, if we agree to have questions come in as I speak, I will continue if there are no questions with my presentation. Otherwise, we can stop for questions. As I said, I'll otherwise just, again, as I said, show a few other developments. So where GRADE has gone and demonstrate a little bit more work around the evidence decision frameworks. But I will stop here for a question. Is there a structured language of obligation for wording the recommendations beyond strong or conditional? That is, clinicians must offer, should offer, may offer, or to be able to translate into encoded and programmable language for decision support. The answer is that in GRADE, we've tried to retain a degree of flexibility because we felt that language and artificial constraints are producing more barriers than actually being helpful. So, but to answer your question, what we have done in GRADE is we've provided suggested wording, 3 typical ways of phrasing recommendations that we ask guideline developers to adhere to. So, for instance, we are against using the word clinicians should consider, because everything should be considered by the time that you're looking at a recommendation, you already considered it. So, to answer your question, there's 3 suggested types of wordings. In particular, around strong and conditional. For strong recommendations in the English language, we use the word recommend. For conditional recommendations, we use the word suggest. So in other words, the ASH guideline panel suggests using low molecular weight heparin over unfractionated heparin. So there is that type of suggestion made by GRADE. Okay. If there are no other questions, I'll quickly touch on the evidence to decision frameworks and provide an example for the development effort, which I think is very relevant for our context. So first of all, GRADE supported the Ibero-American GRADE and Cochrane centers, and we at McMaster supported European breast guidelines quite recently, provided portal information directly coming from GRADE for different target audiences. So for instance, you see that how parallel this is to what we did with ASH, just a different interface that was directly pulled in and was tailored towards how the European Commission wanted to present this. This is on breast cancer screening with assessments. Again, linkage to interactive summary of findings tables, and this was based on the evidence to decision frameworks, where I wanted to emphasize the research evidence, the judgments that a panel makes about, for instance, desirable effects and undesirable effects. And this would be done for every single criterion and an evidence to decision framework: values, the balance of the effects, resources, cost effectiveness, equity, acceptability, and feasibility, to at the end arrive at a recommendation on the basis of the individual judgments or the criteria that are being made. So for instance, the problem is a priority. There were moderate desirable health effects, but also moderate undesirable health effects. The certainty of the evidence was moderate. At the end, this information in this decision grid, the summary of the judgments, is used to make a recommendation. When the stars are not aligned, we typically make conditional recommendations. And that is then directly translated again into presentation formats for different types of groups. So this provides, Brian, also to get back to the health system question, a record of the information and what a guideline panel thought when they looked at the evidence and the judgments that they made after deliberation. Now, this information can be particularly helpful for groups that, for instance, want to utilize this information and possibly adapt it to local circumstances. So coming back to the rapid learning health systems, it is possible that resources in a certain jurisdiction are different, and therefore a deviation from the recommendation, for instance, by not being able to pay for it, is justified. They can use this information and find out that the guideline panel made a recommendation against, for instance, an intervention, for an intervention because it was considered cost effective. Now, when you apply your local circumstance, it may not be cost effective anymore. You may make a conditional recommendation against. Or in this particular instance, this was dealing with organized mammography screening. In the US, there is no organized mammography screening. A guideline developer that deals with mammography could say, okay, in our context, no more organized mammography screening. What does that mean for the detection rate and for cost, for instance? Okay, so the way that this information can be used is laid out in a framework that we call GRADE development. So adoption, adaptation, and de novo development basically deals with making the process of guideline development more transparent. And essentially, the idea is, what if we could take advantage of existing efforts in guideline development? So remember what I showed a bit earlier. If all of this information was available, in particular the summary of findings tables and the evidence to decision, as well as the recommendation, as fundamental units, one could utilize that information to formulate recommendation for a different setting and integrate possibly local contextual information. And in a nutshell, although this is only really a nutshell, that if a guideline panel judges and agrees with the information in an ETD, it may adopt a recommendation. If it is not okay, based on updates, there is some differences in the effects, or the judgments are really different, the cost information, for instance, is different, it may adapt the recommendation. And if there's major work needed, or a guideline panel ended up not making a recommendation because it felt the evidence was insufficient, but in an update there is new information, one may create a new recommendation. So in a nutshell, development works like this, and I'm going to quickly present work of a large project that Ignacio Neumann led in South America based on the ASH guidelines. So development basically works by setting groups and goals, prioritization of guideline topics for different settings that may be based on an original guideline, and possibly updating systematic review and identifying local data, for instance, around cost and utilities, updating grade tables, obviously training is involved, and then formulating and rating of the strength of the recommendation and feedback. And so the way that this might work, if you think of it, there may be 6 recommendations for which you have available the summary of findings, the evidence to decision frameworks, and the recommendation. No change means it may be an adopted recommendation. If you have to make lots of edits, change the judgment, possibly the direction and strength of recommendation would be an adapted recommendation, or you might have to do a new recommendation. And So I mentioned the 10 topics that we are addressing with the American Society of Hematology. These are the 10 topics, and Ignacio led an effort that was focusing on the first 6 guidelines and identified a number of questions utilizing the summary of findings tables and evidence decision frameworks in the tool, in the software, by just sharing this online and working with the local guideline panel using this approach. As I said, they focused on 22 questions that dealt with prevention of VTE, 20 questions that dealt with management. They did an online survey for question prioritization, reviewed the ETDs that were shared directly online. So it was just a mouse click for them to have this information available, and then had an in-person discussion around the recommendations, 42 questions. Interestingly, so this is a South American project across South America, 8 recommendations changed direction, 5 recommendations changed the strength, and they utilized the summary of findings tables that were previously provided. So, for instance, one example was whether in acutely ill patients low molecular weight heparin or unfractionated heparin should be utilized. What this basically means is 1 injection versus 2 injections a day. Patients typically don't like 2 injections, more effort for nursing staff, obviously. However, in terms of what these interventions cost in various settings, there's a lot of variability. And for some jurisdictions, it may make sense to continue with 2 injections of unfractionated heparin as opposed to 1 injection of low molecular weight heparin. Obviously, cost would change. All of that would be influenced. So that, and then there are issues around whether or not low molecular weight heparin would be available to all, that the original recommendation, which is presented here, was somewhat changed in the context of a different setting with a clear explanation for why this actually took place. So that is a way of doing this, and the way that we anticipate this to be working is through the software tool, so that you have the information from the original guideline panel, you share this, and then the guideline panel that would possibly do an development would notify what is different, would describe what is different in their setting, and why a judgment, change a judgment, and why a judgment would potentially be different. So that at the end, they, through sharing of the information, go, for instance, from a conditional recommendation against an intervention to a conditional recommendation for an intervention. We have 2 more test cases. One is a breast cancer screening guideline in Tunisia, and Mediterranean guideline that was done in collaboration with the American College of Rheumatology. There's a publication by Andrea Darzi that makes this out. And the way that Ignacio described it was that you use these GRADE guidelines, but the local panels own the decision. I call it the I. Neumann approach. And finally, the last question that was asked was about whether or not there's a database with all GRADE publications. I mentioned that the methods papers are in part on the GRADE Center website here at McMaster. For all of the guidelines, there's a new tool that I described. It's called the BIG database, that is developed by the Pan American Health Organization, and that will be shortly available. We are talking about the future for those who are looking at that online. So there was a question. I will deal with this question. How do you consider values and preferences in final rating of the recommendations? So this is an excellent question. So our recommendations, or GRADE recommendations, if you look at the way that they are presented, I take this example, typically describe the strength and the certainty of the evidence. But as you see, so here, we have changed in newer recommendations some of the wording, and it says low certainty of the evidence about effects. In other words, we still believe that obviously the evidence about the benefits and harms is the driving factor for a recommendation. You know, if there is no benefit, then what's the sense in looking at values and preferences and so on? But it is also true that now if we start rating the certainty of the evidence, for instance, in values and preferences, that information will potentially play a role. And the way that we express it in the evidence to decision frameworks is best expressed by this particular question that I will come back to. Is there important uncertainty about or variability in how much people value the main outcomes? When there's a lot of uncertainty, in other words, we really don't know what is important or what is a critical outcome, or when there's a lot of variability based on the research, then the recommendation shouldn't be a strong recommendation, because at the end, the relative importance of the outcomes is one of the other driving factors for a recommendation. And that's how we would consider it. So a lot of uncertainty or variability around the values and preferences means a conditional recommendation. And we often then describe how good the evidence for that is, in particular if it's a driving factor for making a conditional as opposed to a strong recommendation. Jojo, I hope this answers your question. And with that, we could be at the end of at least my presentation, Brian.
Great, thank you so much, Holger. That was extremely informative, and I think all of us really appreciated it. We had a very large turnout on the webinar today, and I think a lot of people gained a great deal from your time and your wisdom. So we really appreciate it, and thank you to everyone who participated today. Let me end just with a couple of quick reminders. Keep an eye out for future email blasts regarding the next webinar when it comes down the line. Don't forget to submit your abstracts for GIN 2019. The deadline's in just a couple of weeks. And of course, next week we will be posting the slides and the recording of today's webinar on the GIN website. So you can go back and review, you can share, and you can enjoy again. All right, thank you, Holger, and thank you, everyone. Have a good afternoon.
Thank you. Please stand by.